Well, the good news is this is going to be very brief because morning tea's coming up. So I'm just going to talk about exercise in heart failure, which, you know, going back a few decades would have been a contradictory concept. But the reality is that if these patients sit on the couch or get wrapped up in cotton wool, they're going to do worse than if you get them out and exercise. But of course, how do you do that? That's really the difficult part. So we've heard a lot about heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction, but at the end of the day, it's all heart failure. So we're talking about both groups. So why do these patients get breathless? Well, there's lots of different reasons. They've got a reduced cardiac output, so their heart's in trouble, but also the rest of their body is in trouble. So they'll get skeletal muscle atrophy because they tend to decondition. There's actual changes in the function of their skeletal muscle. They'll tend to accumulate lactic acid more quickly. They get a respiratory muscle weakness, so their actual work of breathing is affected. They can get a relative anemia. And of course, they've often got other comorbid problems like lung disease, like getting older, like having arthritis. So there's a number of different exercise types, but the one that we're really talking about is aerobic exercise because that has the most benefits. But in a lot of cardiac rehabilitation clinics, we're also going to work on some weight training. Now, I don't mean heavy weights, we're talking about weight training. And we can also incorporate inspiratory muscle training, which is what we would normally call pulmonary rehabilitation. So really trying to look at all the different aspects that are contributing to their exercise intolerance. So the initial prescription depends on their baseline. So obviously there are people who are short of breath walking 10 metres, and then there are people who can, walk down to the shop to get to the paper and get back, and they're doing okay. But it doesn't have to be rocket science. So you can kind of pitch it at where you think the patient is at, but the important thing is to give them some guidance. And I often do this with my patients by actually writing out the prescription. Usually their respective spouses love this because their spouses have trouble getting them off the couch. So if you write something down, you say, I want you to do 10 minutes a day of walking on the flat, and that's what I want you to do for the next month. They've got something in black and white that their spouse can berate them with. So I think that whole thing around social pressure is really important because if you say, look, you've got to exercise and I'll see you in 6 months, it's not going to happen. There's a lot of good safety data around this, so don't be afraid that pushing your patients to exercise is going to be a problem in terms of safety. You want to advise the patients to pick a good time to exercise, so if it's 39 degrees outside, don't go outside. Go to the local shopping centre where it's nice and flat and air-conditioned. There's various groups that you can join, whether it be a formal cardiac walking group or just getting out with a group of friends. But I think the whole social aspect of exercise is really important, and whereas you'll always stand yourself up for an exercise date, you won't stand up a friend. Advise them not to exercise after a big meal because half their cardiac output is busy digesting their meals, so they won't feel great exercising at that time. And then as they get started, we want to increase the intensity and the duration. So there are actually measurable benefits from aerobic exercise, and this has been documented in research. So you do get an improvement in the actual measurable cardiac volumes, in their diastolic function, in their VO2 max. And there's a lot of various remodelling that goes on out at the periphery with the skeletal muscles. Other benefits are that depression, which is extremely common in heart failure, is reduced. There's reduced hospitalisation, reduction in mortality, but the most important thing is improved quality of life, and I think that's where patients can really benefit. So at the end of the day, exercise is good for them. So if you want to just get them out there, get them exercising, whether it's through formal cardiac rehabilitation, whether it's through engaging their spouse or their friends, getting their care plans organised so that they go and see an exercise physiologist as part of their care plan, giving them your own prescription, getting some friends involved, using their Fitbit, which some of them love. However you do it, as long as you get them out there and get them exercising. And with that, I'll conclude my talk. And I don't know if you want to do questions or go straight to morning tea.
That was brief enough to give some time for a couple of questions before we break. Anybody with a pressing question? And otherwise we can break for morning tea and you can come and have a chat with the speakers. Any pressing questions? Yes.
I wonder if those cardiologists can explain why the recent death of that three-time Ironman.
Dean Mercer.
Yes.
Okay, Louise.
I haven't heard anything about the autopsy. What I hear from the Courier Mail was that it was a sudden cardiac death that led him to crash his car. And this has led a number of my friends who are high-level athletes to go and have their CT done, one of whom has since had a stent. So you can be a high-level athlete, have a moderate lesion, be doing your Ironman one day and have a sudden cardiac death event the next day. There are a number of possible mechanisms. So you could have a moderate plaque that ruptures. You could have a severe plaque that's asymptomatic. So about 20% of patients will not manifest symptoms until they have their heart attack. He may have had a cardiac arrhythmia as a consequence of that. So there's all sorts of possibilities, but I don't actually know what the autopsy results were. But we're...
phenomenon of the athlete's heart is dilated cardiomyopathy that some of them end up with, which sometimes seem arrhythmia prone. He's not the first athlete to have one of those. And of course the hypertrophic cardiomyopathies that are induced by training can also cause that as well. And it all depends on what kind of training he was doing and arrhythmia prone events.
Yeah, so interestingly, we've had a number of patients who've come in after either during Ironmans, during triathlons, and we've seen a variety of scenarios. And there's actually a recent paper on sudden death in triathlons that's looked at this, because obviously these guys have been training every single day, they're high-level athletes, but still there's this random thing that can occur, and I think there's a variety of different reasons why these people drop dead, and they don't always drop dead at the end of the triathlon. Sometimes it's at the beginning. So it's a very worrying thing. And should they all go and get screened? Well, I think there's now a recommendation that over a certain age, if you're going to engage in high-level extreme sports, that screening your heart is worthwhile.
Wanted to ask, is there any understanding about how prevalent the use of the bodybuilding steroids and other, the drugs that the athletes do use? We know that they use them, but do you know what sort of...
Look, it's extremely prevalent if you go to the gym in Nunda. I have that from a friend. So I think in the gym environment, steroids are still rife, and of course we know even in high schools it's out there. I have seen a number of patients who've had premature onset of coronary disease from steroids. In terms of the elite athletes, I'm not sure, but I'll hand it over here.
I would like to make some comments. So actually, in my early stage of my career, when I was working in Scotland, I was trying to do a big study with the athletes to define whether they got any cardiomyopathy. We tried to use the MRI, sophisticated at that time, maybe tissue Doppler, all the measurements. And actually we progressed pretty well. And with some reasons, study was actually stopped. And because of that, I can tell you one reason is that majority of the athletes at that time was using something. And actually they've been coming very interesting to have the check a heart because they would like to check whether the heart is bad for them or not. And to distinguish in doing the study, proper study, whether this is related steroid or not steroid, I'm not saying steroids, or any stimulant medications to have negative impact on the heart muscle is exceptionally or virtually I think is impossible. How can you go the ethics to get approval that someone using steroids, someone's not. So it's actually cannot be done. But I think generally speaking it's bad. extremely high level exercise might bring something which is underlying the patient, because we know of the age and there could be some problems, and all this medication could produce the, as Louise mentioned, the coronary disease, steroids, but they also could produce tachyarrhythmias. That might contribute into the heart muscle dysfunction, low level, which might be okay if they're not doing exercise, but might contribute to sudden cardiac death.
Thanks. Yes, and we're certainly seeing, in my husband's practice, for example, increasing incidence of avascular necrosis of the hip in young people as a result of this widespread use. I think we'll finish there. This has been a great session, and I think a wonderful update on heart failure management. Thanks, everyone, for the excellent talk.